As we talk about postmenopausal bleeding, I think a very, very common complaint as we see in our OPDs and as we are talking about menopausal clinics, as Dr. Pushpa Sethi said, to inform her that we recently started our menopausal clinic at Lady Hardinge Medical College in full go. And this is one complaint of a patient which needs an evaluation with expertise and an evaluation of the patient as whole. So with the shift, why are we so worried about menopause now? So with the shift in demographics towards an aging, increasingly obese population, we are likely to see a rise in estrogen-dependent endometrial pathologies, including cancers and other problems. So we need to be familiar with the evidence-based recommendations, investigations, and diagnosis of this problem. So certain definitions, postmenopausal bleeding, that would be after 1 year of amenorrhea in a woman in a menopausal age group without any contributory factor for amenorrhea. For example, patient is not on any hormones or other things. A breakthrough bleeding we define as an unscheduled uterine bleeding which is encountered in any postmenopausal women using an HRT. Persistent bleeding would be defined as something which is continuing for 1 month, and recurrent postmenstrual bleeding has not been clearly defined, but definitely after a recurrence which occurs after a negative initial investigations. Or we can say that any bleeding episodes separated by periods without bleeding, or another NHS has defined it as after an interval of 6 months with 2 negative biopsies. So an overview, majority of the patients would have a benign cause. 10% would have a gynecological malignancy, and most of the patients may present with endometrial and cervical cancers who are with malignancy. And patients with endometrial cancer would present 90% of the time with a bleeding. We should rule out other factors like vaginal, vulval, and ovarian cancers and fallopian tubes, which are rarely the causes of postmenopausal bleeding. But the catch point is the last line, that whenever a patient presents, we should definitely investigate the patient in whole to rule out a rectal, urinary, and a systemic problem. So the common causes would be highlighted that atrophic endometritis and vaginitis occurs in 60 to 80% of the cases, and cancer endometrial in only 10%. The rest of the pathologies can be polyps, hyperplasias, or cervical cancer. So if we do a biopsy, what all do we find? We may find the proliferation, we may find a cystic atrophy, simple hyperplasia, atypical, a variety of things, endometrial cancer, or we do an ultrasound, we may find intracavitary lesions like fibroids, we may find adhesions, we may find adenomyosis or the thickened endometrium. So a patient with postmenopausal bleeding requires a prompt and effective evaluation to rule out cancer, that's the prime target, and to rule out the precancerous lesions plus find a diagnosis. So the clinical history should identify all the risk factors for endometrial cancers or endometrial pathology like duration of the symptoms, her age, nulliparity, early menarche or late menopause. These are the high risk factors for endometrial pathology. Obesity, type 2 diabetes mellitus, polycystic ovarian syndrome, hypertension, patient on HRT or tamoxifen, or she has a family history of malignancy, or she fits into an HNPCC, that is hereditary non-polyposis colorectal cancer syndrome. And the examination should include a full investigation of her weight, height, BMI, her systemic investigations, her lower genital tract, as a patient may simply be having a polyp sitting there, or she may simply have an atrophic vaginitis. So as far as routine investigations, we all know we should assess this may be a first point of care for this patient in a hospital. She's had normal deliveries at home and this is the first time she's coming to us. So this is all the window of opportunity to treat her properly, find out her diagnosis and evaluate her comorbid conditions like hypertension, diabetes. Then specific investigations like a transvaginal sonography, office-based endometrial biopsy, saline infusion sonohysterography, and hysteroscopy. I've written DNC first and I'm speaking it last because that is practically out. The best diagnostic strategy is yet to be determined, but then yes, there is a choice between transvaginal sonography or office-based endometrial biopsy as the first step of investigation. We will see which one to choose when. So transvaginal sonography is a reasonable alternative to endometrial sampling as a first approach in evaluating a postmenopausal woman who's come to us with the first episode of bleeding. but then this should be in a low risk patient. The transvaginal sonography is a very, very detailed assessment which is needed through TBS, and it should not be done by any person who's not very competent in doing it, because this information is very important, which cannot be given by a transabdominal sonography. So what are we looking at a transvaginal ultrasound? Now the term is not simply ET. The term is endometrial echo-complex evaluation. So your uterus that we are visualizing should be seen in entirety in the sagittal plane, right from the fundus to the cervical canal. Any presence of polyps, fibroids, or ovarian morphology should be described in detail. The endometrium should be measured at its thickest part from one visualis layer to the other. That is an anteroposterior 2-layer thickness in sagittal plane near the fundus should be measured. If there is an endometrial fluid, it should not be included in the ET measurements. And we should also understand that TBS is not the endpoint. Meaningful assessment of the endometrium by the ultrasound may not be possible in certain patients. For example, if a patient has an axial uterus, patient is very obese, even a TBS may not help. Coexisting myomas, adenomyomas, previous uterine surgeries may make the assessment of ET difficult. So in such cases, alternative investigations should be done. Now, we've done a TBS and we find that the thickness is less than 4 mm. We are very sure that 99% this patient is going to be negative for endometrial cancer, and the chances are only 0.6%. So a patient who's presenting with a bleeding for the first time with the ET of less than 4 mm, we may not do a biopsy. The recurrence rate with an ET of less than 4 mm would be 10% with less than 4 mm. And if by chance it is more than 4 mm, it would be 20% where we should interfere. Now, is it a rule that if the ET is less than 3 mm, we will definitely rule out a malignancy? This is a question which keeps on bothering us in so many clinical situations. So if the patient has an ET of less than 4 mm, which is homogeneous, thin stripe, we may be ruling out a malignancy. But at times, if the patient is presenting with persistent or recurrent bleeding, then irrespective of the ET thickness, we should do a sampling, because we may not rule out a type 2 endometrial cancers, papillary serous, mucinous clear cell, etc., just by a distinction of 4 mm. So if the patient is persistently presenting, we should do a sampling. Now, which should be first? This is even asked as an MCQ for the undergraduates and the postgraduates. A patient is presenting with postmenopausal bleeding, we should do an ultrasound or an EB. And sitting in tertiary care centers, we find this question slightly out of apt because we do both. But ultrasound should only be done where we find that the patient is of that low risk that if we find an ET of less than 4 mm, we are going to leave this patient. But if the patient is high risk with obesity or with high risk factors or a family history where we find that higher chances of endometrial cancer is there, then we should evaluate the patient by both methodology. Endometrial sampling should be the first line. Now, when should we do an EB? If we find that the patient is high risk with an ET more than 4 mm, ET is not clearly visualized, persistent bleeding regardless of ET, suspicion of a mass or a polyp, if the blind sampling does not reveal an endometrial hyperplasia or malignancy, and the patient has recurrent bleeding, we should further evaluate her by hysteroscopy. And patient has a 3 mm ET, but she also has a fluid. We should do an endometrial biopsy. Which one we should do? Outpatient or inpatient under GA? So the recommendation is that the outpatient endometrial sampling with the disposable device is good enough unless the patient wants a general anesthesia. So all the disposable devices like Pipple, Vibra, Explora, etc. are good enough.
Another 3 minutes, please.
Yeah. The hysteroscopy is the gold standard for evaluating the endometrial cavity. It finds the macroscopically focal abnormalities. We can do a gross view and we can do the sampling, and we can even treat the polyp at the same indication. So hysteroscopy is definitely indicated when we cannot pass the Pipples for an inadequate biopsy. We have a suspicion of a polyp. We cannot adequately visualize the endometrium, or the patient has a recurrent postmenopausal bleeding. There can be a condition where we cannot do an endometrial biopsy in a postmenopausal bleeding in spite of giving her a general anesthesia. Then the whole patient should be evaluated and decision should be taken accordingly. One may move on to an axial scanning like MRI, etc. in this patient. So asymptomatic thickened endometrium more than 4 mm, you do not need to bother much if there is no high risk. But yes, if it is more than 11 mm, one should do an endometrial biopsy. If it is an endometrial hyperplasia without atypia, 2% chance of becoming malignant, patient should be put on progestogens, and repeat sampling after 6 months is important. One should understand that cyclical progestogens are not very good. We should give them continuous progestogens or LNG-IUS, which should be the treatment of choice for these patients. And when the patient has 2 consecutive negative biopsies, we feel that she's treated. Atypical hyperplasia needs treatment because 23% chance of her becoming malignant, preferably a laparoscopic hysterectomy, and lymphadenectomy is not needed in this patient. A special slide on patients on tamoxifen who present with postmenopausal bleeding. They definitely have a higher risk of endometrial hyperplasia and cancer. So a routine screening on a patient with tamoxifen is of limited value. But if the patient is presenting to us with symptoms, then she should be evaluated like any other patient with postmenopausal bleeding, and a threshold of 5 mm should be kept. In a tamoxifen-induced hyperplasia, we should be careful that the patient may have a subendometrial hypertrophy, which may not be picked up by the TBS. So if the patient is symptomatic, we need to do an endometrial sampling. Now, women on HRT presenting with an unscheduled bleeding, they need evaluation if on a continuous therapy after 6 months they present with bleeding, or once an amenorrhea is established, or on a sequential therapy after the progestogens they have a heavy or prolonged bleeding, or at any time they have a breakthrough bleeding. We need to evaluate these patients. And the risk of endometrial cancer, we all know, in a patient who's already been evaluated by us and we are giving HRT to her or a menopausal hormonal therapy is less. A threshold of 4 mm, as in women not using the HRT, should be used to select for further investigations. And patients should be advised to continue using HRT while we are doing an investigation for postmenopausal bleeding. So what can be the treatment? For a sequential regime, we can change the progesterone. For those with continuous HRT, if it is more than 4 mm, then we can, and a negative histopath, and we have used the MHT for less than 1 year, we can switch over to a sequential HRT. And if it is more than 1 year, we can decrease the dose of estrogen and change the progestin. Senile endometritis, the most common cause, would be treated by conjugated estrogen 0.625 milligram. And we see an improvement in 2 weeks. For atrophic vaginitis, local estrogens are important. Polyps, if presented on a TBS for a patient of postmenopausal bleeding, should be biopsied, and a hysteroscopic removal can be done. The question is, if the patient has an asymptomatic polyp, then what do we do? A symptomatic polyp, higher chances of malignancy, treat it. An asymptomatic polyp, whether we leave it or we keep her on a follow-up or we treat her, would depend on the size of the polyp, symptoms, she doesn't have any, and the background risk of this patient. So an individual assessment is needed, and accordingly we can treat or follow up this patient. But right away, we do not need to manage this polyp. So to conclude, postmenopausal women presenting with bleeding should be investigated in detail, managed promptly, and a detailed assessment should be done. Transvaginal ultrasound measurement of endometrial thickness is a useful technique for preliminary evaluation of these women. Direct endometrial biopsy is indicated in symptomatic women with a thickened endometrium or a postmenopausal bleeding. Asymptomatic women with an incidental finding of an increased endometrial thickness need to be managed on an individual basis, taking into consideration their risk for endometrial cancer, the actual thickness of endometrium, and any other positive findings on the TBS like local findings, submucous fibroids, or a mass. The literature does not support routine screening of asymptomatic postmenopausal women for endometrial cancer, as it has not been proven efficacious. Thank you for the time and chance.